The next topic is IOM of the tethered core syndrome surgery. It's my great pleasure to introduce Professor Yang from Taipei Veterinary General Hospital to this wonderful speech. Professor Yang graduated from the National Yangming University, and she is the attending physician at the Department of Physical Medicine and the Rehabilitation, and also the chief of the Children Development Center in Taipei Veterinary General Hospital. Her main research interests on pediatric rehabilitation, neurological rehabilitation, swallowing disorder, and intraoperative neurophysiology monitor. Let's welcome Professor Yang with warm applause. Professor Yang, please.
In this session, we will focus on mapping and monitoring techniques during surgery for tethered cord syndrome. Tethered cord syndrome implies that the caudal end of the spinal cord is attached to bone or other inelastic tissue that will induce metabolic and vascular changes within the distal spinal cord and the nerve root, and which might result in sensorimotor complications of lower limbs, bowel, bladder, and sexual dysfunction, and also musculoskeletal deformities such as scoliosis and club feet if the situation is not managed before the irreversible nerve damage does occur. This table illustrates possible causes of TCS we encounter in clinical practice that require detailing. See how challenging it can be to detail the intermingled neural structure from this bulky fatty tissue. This article from Neurosurgery Focus, published in 2010, stressed the role of NIOM in detailing surgery. These are presenting symptoms in their 38 cases. The distribution of tailoring elements, including scar, precord, filler, lipomatous tissue, and except for one case with worsened bowel and bladder function, the rest of them were either improved or at least stay stable after operation, which certainly confirmed the critical role of NIOM during detailing surgery. This article, published in 2019, compared the result of detailing surgery with and without monitoring. It included 102 surgeries related to this pathology. They concluded that the NIOM can reduce the perioperative surgical risk significantly and also beneficially in avoiding the long-term progression. Detailing surgery aims to halt the progression of functional deterioration in TCS. It involves resection of the tumor to release the spinal cord and the nerve roots. Need to pay attention to protect the nerve roots and the functional structure at risk during detailing. For instance, like this one, before resection of lipoma, it's very hard to tell the intermingled neural structure from the fatty tissue, and the future retailing can be avoided if total resection can be achieved each time, like this one, before and after resection of lipoma under guidance of the NIOM. Nowadays, it's believed that early and total detailing not only can prevent progression but also lead to clinical improvement if it's performed before irreversible functional damage does occur. It involves a very meticulous dissection of the nerve roots from the tethering elements, whatever it might be, and possible injury to the nerves supplying the lower limbs or sphincter can occur during the dissection, which highlight the important role of NIOM during this procedure. Let's talk about how to use multimodality techniques to guide the surgeon's dissection and preserve functional integrity at the same time. In this procedure, lumbar sacral roots and the spinal cord, including corners, are at high risk. These are the modalities we used in general. We will monitor MEP and free-run EMG from bilateral lower limbs muscle and the external anal and the urinary sphincters. We will monitor SSEP of posterior tibial nerve and the individual dermatome if indicated. The most important part is to use triggered EMG to identify motor structure. However, we should also try best to do sensory mapping and preserve sensory function as well. H and the bubble caverns reflex are regional reflex circuit and certainly have important roles here also. Triggered EMG is the most critical part of IONM here. Because local anatomy is frequently distorted by tethering elements, use triggered EMG can identify functional structure from tissue that can be compromised, for instance, fat or fibrous band. We directly stimulate the structures of interest with a handheld bipolar stimulator, and for smaller infants, we prefer a concentric one, and record a response from lower limbs muscle and the external anal and the urinary sphincters as well. For nerve roots, the stimulation threshold being 0.5 to 2 milliampere, and for cord, 5 to 6 milliampere will do. This slide shows that the surgeon used a concentric stimulator to identify any functional motor structure, which will result into a CMAP response right after the stimulation. And we monitor response from bilateral lower limbs muscles, from external anal sphincter with needle electrode, and from external urinary sphincter with surface electrode attached to a Foley catheter. Timing of triggered EMG, including to identify neural tissue during exposing and dissecting the tumor, and before untethering or tumor removal, to make sure there is no functional structure, and to identify and dissect feeder. Under that circumstance, we will use higher threshold up to 20 milliampere to make sure there is no motor response before dissection, and also after untethering and tumor removal, we use triggered EMG to verify the integrity of motor pathway and predict the prognosis by comparing the threshold before and after release. We can monitor the status of motor roots with free-run EMG as we used elsewhere. However, we should be able to distinguish EMG activities triggered by mechanical irritation from other types of signal, for instance, light anesthesia. most muscles are firing altogether and from pre-existing denervation potentials, so a baseline should be set for comparison. And of course, false negative and false positive results do exist. And free-run EMG here can provide better sensitivity than specificity, which means it possesses lower false negative rate but higher false positive rate, possibly related to route manipulation. And we also need to alert surgeon if the response is long-lasting and persistent. This is the spontaneous activities from bilateral anal sphincters. Another important modality is transcranial MEP, used to safeguard the integrity of motor function during dithering. This is the 4-month-old girl. We need to use approximately 500 volts and 9 counts of trans stimulation to get a stable response, certainly much higher than we use for older population, and see how their MEP have more phases and longer duration compared to grown-up, owing to the immaturity of their nervous system and a lesser degree of myelination in this younger population. If for some reason MEP cannot be elicited through transcranial stimulation even after vigorous trials, we can use a strip placed at the subdural space just proximal to the surgical field and stimulate the spinal cord directly and record a response from leg muscles. And this is the intensity recommended, but frequently much lower intensity will do. Although it might activate sensory pathway instead of motor pathway directly. However, since we record the response from leg muscles, it's still enough to safeguard the motor function of coda equina. And the latency of response certainly will be shorter than the response from transcranial stimulation, owing to the shorter distance between stimulating and recording electrode. SSEP of posterior tibial nerve is used to monitor sensory function of lower limbs here. However, it's very challenging to record cortical SSEP in patients younger than 1 year old, owing to the immaturity of their nervous system. So again, we developed a novel application, use the same strip placed at subdural space to replace the scalp electrode recording. We initially enrolled 23 patients, and 12 of them were younger than 1 year old, to compare the response recorded with subdural strip and scalp electrode. And with exception of one patient, the amplitude of subdural SEP was much larger than the cortical response, and in 9 of them, a cortical SEP was not obtainable. Moreover, since the subdural response was much larger and straightforward, much less averages were actually necessary to get a clear subdural response compared to the cortical recordings, so we actually save much time with this novel application. And if any individual sensory root is at risk, we can also use this strip to recall the dermatomal SEP by stimulating the related dermatome with surface electrode, which definitely is not possible to be done with scalp recording. The next modality is bubble cavernous reflex, which can be elicited by stimulating the dorsal pineal nerve in male and the clitoral nerve in female, and recall the CMAP at anal sphincter. It helps to monitor the integrity of S2 to 4 and levels and corners, which is important to bowel, bladder, and sexual function in later life. Typically, stimulus intensity 20 to 40 milliampere, and the response will appear between 30 to 50 milliseconds. And you can also use the train stimulation if the response cannot be elicited by one stimulation only under anesthesia. This article, published in 2018, evaluated the predictive value of intraoperative BCR for postoperative boiling function, and they included 106 cases, and their data indicated that boiling deterioration will not occur if intraoperative BCR is preserved at the end of procedure. Some recommend to monitor external urinary sphincter as well. The response can be recorded with a commercialized recording device. This is CMAP of EUS when doing triggered EMG, and this is MEP by transcranial stimulation. Another regional reflex is H reflex, can be used to monitor the integrity of S1 circuit whenever indicated. And for a long time, it makes no sense to me that we seem to focus much more on preserving motor function by doing motor mapping mainly, but spend no time to do sensory mapping to preserve sensory function as well. But if you stimulate with a handheld electrode and record SSEP from scalp electrode to identify sensory structure, it might need more than 200 averages, which is so time-consuming and impractical. So we developed a novel application by recording it with the same strip, subdural strip, during sensory mapping to replace scalp recording, and the response is so standing out. It frequently requires less than 10 averages, which means it takes only 2 to 3 seconds to do it. It's much more practical in clinical use. So, surgeons use concentric electrode to stimulate at whatever of concern, and the structure with resultant SEP should be preserved, and the structure without response should be safe to dissect. In this way, not only we can preserve motor function by monitoring CMAP response, but also we can preserve sensory function by monitoring SEP response with this particular strip. Now, we will use a case to demonstrate how to use multimodality techniques during deterring surgery. This is a 1 year and a 6-month-old boy with history of myelomeningocele who received a primary repair soon after birth. Pre-operative MRI revealed color tethering. Before incision, this is MEP from bilateral lower limbs muscle through transcranial stimulation. Baseline cortical SEP of posterior tibial nerve. And the baseline BCR. After dura opened, surgeon placed a strip at subdural space just proximal to the surgical field. And first, use concentric electrode to identify functional motor and sensory nerve as usual. We typically will do motor mapping first. If there is CMAP, it's motor structure. If there is no response, we will shift to do sensory mapping and record the response with the strip. Look at here. Some traits have response, some does not. So it's then safe to dissect the structure without any motor and sensory response. In this way, we can preserve both motor and sensory function at the same time. And finally, surgeon stimulated the precord from upper part and stepwise downward, and recorded the response with the same strip to identify the lowest portion of functional corners. And in this case, both sides had no response below S4 level. Precord was detected below the level without any response. After complete detailing, MEP remained unchanged. Both cortical SEP and SEP recorded with the strip remained stable. BCR was still elicitable with same threshold. In our first 6 cases used this sensory mapping, who had been followed for at least 1 year. There was no one with functional deterioration after operation, and 3 of them actually showed some functional improvement. This novel clinical application was accepted by JNS Spine in 2018. In conclusion, deterring surgery does carry risk of damage to neural tissue and neurological deficit. Thus, combined use of multimodalities during NIOM can help to reduce this morbidity. And many previous series denoted that the improved neurological outcome with monitoring and how surgical procedures were changed because of the information provided by NIOM. And it's believed that deterring under guidance allows for more aggressive dissection and hopefully can reduce the retearing rate in the future. In recent 10 years, we have conducted more than 170 cases of deterring surgery, and they aged between 1 month old to 57 years old, and 75 of them were younger than 1 year old. No need to say it's pretty challenging. And the feedback from our neurosurgeon has been very positive regarding to the role of NIOM during this procedure. And thanks for listening.
Thank you for your excellent lecture. There are some questions from the audience. The first one is, what is the youngest age that TCM-EP can be done? And the infant myelination is incomplete. Is 500 voltage for TCM-EP safe?
Okay. My personal experience is the youngest baby I was doing was 1 month old. But from the previous article, I know some researchers, they actually have done baby younger than 2 weeks old. So again, because their nervous system is immature, you need to use much higher intensity to get the particularly the MEP response. So that's why your second question is that safe? We use the 500 volt to elicit the MEP, but the good side is that because MEP is not done continuously, we actually during this kind of procedure, the major tool we use is trigger the EMG. So we probably would do MEP check like every 20 minutes to check the condition. So we are not going to use that very often. But from my understanding, some institute they start to investigate the possible damage to the brain after the transcranial stimulation or direct cortical stimulation in animal study, but we haven't see any result so far. But as I mentioned earlier, we only do that intermittently. So at least so far, we haven't seen any short-term damage. But of course, we need to follow them for longer term.
Okay, thank you. The next question is how to monitor sexual function of special male patient.
Okay, we do not monitor sexual function intraoperatively, and particularly we are talking about this younger population. But theoretically, sexual function is supplied by similar innervation as the bowel and the bladder function. So basically, we use BCR to monitor the reflex arc from the sensory input to the motor output. So hopefully, by preserve this reflex arc, we can preserve the sexual function later on.
Okay, because the time is limited, I will end this section. Thank you for Dr. Yang for your wonderful speech.